This recorded lecture will be going over Chapter 13, Care of Patients with Disorders of the Upper Respiratory System in the MedSurg textbook. The upper respiratory tract includes the nose and sinuses, mouth, the pharynx, and larynx above the vocal cords. Upper respiratory infections include viral and bacterial infections, resulting in cold, flu, pharyngitis, rhinosinusitis, epiglottitis, laryngotracheitis, and pertussis. Trauma and allergies can also cause nose and sinus disorders. The common cold, acute viral rhinitis, is an inflammation of the nose and upper respiratory tract. Other names for a cold would include nasopharyngitis, rhinopharyngitis, acute coryza, and head cold. It is the most prevalent infectious disease among people of all ages. Avoiding exposure to those who have a cold and maintaining a state of good health are the only ways that you can avoid catching a cold. Viruses are spread by airborne droplet sprays from infected people during breathing, speaking, coughing, and sneezing, or by direct hand contact with a contaminated object and then contact between that hand and mucous membranes. Allergic rhinitis may have many of the symptoms of a cold, except there is no fever. It is caused by a reaction of the nasal mucosa to an allergen, such as pollen or dust. The common cold usually starts with a mild sore throat or a hot, dry, prickly sensation in the nose and back of the throat. Within hours after the onset of a cold, the nose becomes congested with increased secretions, the eyes begin to water, and sneezing, malaise, and an irritating, non-productive cough will appear. In most instances, a cold will last 7 to 11 days, but it can take up to 14 days before all of the symptoms are gone. There is no cure for the common cold. The treatment of allergic rhinitis is symptomatic. Antihistamines, steroids, and sprays that stabilize the mucous cell membranes are often prescribed. A major goal in the care of the common cold is prevention of a secondary bacterial infection. A person with a cold is contagious for about 3 days after symptoms first appear. Colds can be spread by droplet infection, and most people realize that coughing and sneezing will spread viruses. The patient should stay indoors, preferably in bed or resting during the first few days of the illness. Fluid intake should be increased. Fruit juices are recommended, especially citrus juices, due to their vitamin C content. Decongestant nose drops or sprays containing vasoconstrictors like oxymetazoline can have a rebounding effect, leaving the nose even stuffier if used for more than 3 days. Antibiotics are not given because a cold is a viral infection. A bacterial infection, which requires medical treatment, is likely present when a cold persists for more than 7 to 10 days without any improvement, or if the patient begins to feel worse, has a temperature of 101, or develops chest pains and coughs up purulent sputum. On page 281, see the red safety alert box. The U.S. Surgeon General, the FDA, CDC, American Academy of Pediatrics, National Reyes Syndrome Foundation, and the World Health Organization have all recommended that aspirin and any combination products containing aspirin not be given to any children under 19 years of age during any episodes of fever-causing or viral illness. Adults taking anticoagulants or NSAIDs should take aspirin only under the direction of their healthcare provider because aspirin can further prolong clotting time. Sinusitis is an inflammation of the mucosal lining of the sinuses. This can be caused by infection or allergies. Viral infections are the most common cause of rhinosinusitis. Sinusitis often occurs after colds or other respiratory infections and during periods of uncontrolled allergic rhinitis. People with a deviated nasal septum or allergy problems will tend to have recurrent sinusitis. As exudate accumulates in the sinuses, pressure will build up, causing pain. Symptoms would include tenderness over the sinuses, purulent drainage from the nose, nasal obstruction, and sometimes a non-productive cough. The upper teeth can also become painful. Treatment of sinusitis involves relieving pain, promoting sinus drainage, controlling bacterial infection, reducing inflammation, and preventing recurrence. Hot, moist packs over the sinus area can be helpful. Inhaling moist steam will keep mucous membranes moist, and equipment for sinus irrigation to help promote drainage is available at most drugstores. The infection may be treated with an antibiotic or anti-infective agent, typically for about 10 days. Rest, reduced stress, a balanced diet, and control of allergies can help prevent reoccurrence. Fluid intake should also be increased. Acute or chronic sinus infection can cause a variety of complications, including septicemia, meningitis, and brain abscess. When sinus infection is chronic, surgery to clean out the sinuses may be necessary. Epistaxis, or a nosebleed, is a common occurrence. This typically results from crushing, crusting, cracking, or irritation of the mucous membranes covering the front of the nasal septum. Anterior bleeds are the most common, acquiring about 90 to 95% of all nosebleeds. Blood loss is usually minimal, but about 6% of nosebleeds will require medical attention. Decreased humidity, excessive nose blowing, allergy with inflammation, and nose picking can cause nosebleeds. Overuse of nasal spray, street drug use, and tumors are other causes. Nosebleeds can also result from trauma, hypertension, and blood disorders like leukemia. They are common in boys during pubescence. Bleeding from the nose is the only sign of epistaxis. When epistaxis occurs, the patient should sit forward and apply direct pressure by pinching the nose just below the bone, very close to the face, for about 10 to 15 minutes. This position will prevent blood from running down the back of the throat. Cold compresses or ice can be applied to the nose to constrict the blood vessels. Once the bleeding stops, the patient should rest quietly for a few hours and be instructed to avoid bending over and not to blow the nose, pick at it, or rub it 24 hours after the nose bleeding has stopped. On page 282, we can see the proper placement of the fingers in order to control that nosebleed. And on that same page, we can also see a nasal balloon device that can be used to control bleeding. Pharyngitis, usually called a sore throat, can be caused by a virus, bacteria, or fungus. Most cases are viral. Acute follicular pharyngitis, or strep throat, is caused by the beta hemolytic streptococcal infection. Laryngitis, or inflammation of the larynx, can occur if the infection will progress into the larynx. If the inflammation extends to the epiglottis, epiglottitis will occur. This is more common in children. Epiglottitis can cause an acute airway obstruction and needs to be monitored closely. The symptoms of pharyngitis include a dry, scratchy throat, feeling in the back of the throat, mild fever, headache, and malaise. The throat, tonsils, palate, and uvula can be involved and will be reddened. If swelling of these structures is present, dysphagia can occur. With laryngitis, the voice may become hoarse or absent. The usual course for uncomplicated pharyngitis or laryngitis is 3 to 10 days. The diagnosis of pharyngitis is confirmed by clinical signs and symptoms. A throat culture can often be performed to confirm or rule out the streptococcal infection. Uncomplicated viral pharyngitis usually responds to conservative measures, including rest, warm saline gargles, throat lozenges, antiseptic sprays, plenty of fluids, and a mild analgesic for aches and pains. Bacterial pharyngitis will require antibiotic therapy, particularly if the infecting organism is Streptococcus. Bacterial pharyngitis will require antibiotic therapy, particularly if the infecting organism is Streptococcus. An infection with inflammation of the tonsils is usually caused by viruses such as those causing the common cold. Symptoms are somewhat similar to those of pharyngitis. Acute tonsillitis can occur repeatedly, especially in those with a low resistance to infection. Acute tonsillitis will occur more commonly in young children. Symptoms would include a high fever, sore throat, general malaise, pain referred to the ears, and chills. Inspection of the throat will reveal redness and swelling of the tonsils, as well as the surrounding tissues with patches of yellow exudate. The white blood cell count will be elevated. Chronic tonsillitis will produce an enlargement of tonsillar and adenoidal tissues. A person with chronic tonsillitis and enlarged adenoids will have frequent colds and appear to be in poor health. Diagnosis is by physical examination and history. If a streptococcal infection is suspected, a throat culture or rapid strep test can be performed. A throat culture is performed before treatment to check for the presence of streptococcus. This can cause rheumatic fever or glomerulonephritis if not treated promptly. Acute tonsillitis is treated with warm saline throat gargles and the administration of specific antibiotics, typically penicillin, to destroy the pathogen. Nursing measures would include bed rest, fever management, and a liquid diet to minimize trauma to the tissues and maintain hydration. Surgery can be used to treat tonsillitis when it is recurrent or when enlargement of the tonsils and adenoids obstructs the airways. Surgery is considered if the patient has more than 6 episodes of streptococcal tonsillitis per year. Tonsillectomy and adenoidectomy are done typically on an outpatient or same-day surgery basis. Physical preparation of the patient would involve administering preoperative medications as ordered, restricting the use of aspirin or other NSAIDs, and restricting the patient's diet for 6 to 8 hours prior to surgery. During the postoperative care, be vigilant for any signs of hemorrhage. Vital signs should be checked frequently, and the patient must be observed for any frequent swallowing or clearing of the throat. This can indicate bleeding. Restlessness can be another clue to excessive bleeding. Have the patient open their mouth and assess for any bleeding. Sneezing, coughing, and vomiting can also cause bleeding. A side-lying position when drowsy or the semi-Fowler's position when fully awake can help maintain a patent airway. The postoperative diet will typically consist of cold or warm liquids, progressing to semi-solid foods for the first 24 hours. Avoiding red foods can help in distinguishing between ingested food and blood. Citrus fruits, hot fluids, and rough foods should be avoided until the throat has completely healed. Note that stools might be black due to the swallowing of blood. The SARS-CoV-2 is the organism responsible for the COVID-19 disease. If symptoms are present, they would be similar to upper respiratory infections and include cough, sore throat, fever, body aches, and a congested or runny nose. A unique symptom is a new loss of taste or smell. There can also be GI symptoms as well, including nausea, vomiting, and diarrhea. Mild to moderate symptoms occur in about 80% of the patients with this disease, and it usually does not require any special treatment. If the disease progresses to a severe form, hospitalization and aggressive therapy are indicated. The risk factors for developing a severe case of COVID-19 are primarily having an underlying medical condition, including diabetes, cardiovascular disease, hypertension, and being immunocompromised, being older in age, or being male. The virus causes cytokine release syndrome, which has been identified as one of the mechanisms that triggers massive amounts of post-inflammatory substances. The effect on tissue results in hypotension and acute respiratory distress syndrome. The FDA has approved the nucleotide analog antiviral remdesivir for the treatment of COVID-19. Immunomodulators are being looked at to stop the cytokine release. 3 different vaccines are currently being administered in the United States with emergency use authorization from the FDA. Laryngeal edema caused by the inflammation of an infection or allergic reaction, a crush injury of the larynx, or a foreign object of food that goes down the airway rather than the esophagus can obstruct the airway. If a person seems to be choking, encourage the forceful coughing if possible. If the person cannot speak or breathe, they may make the universal sign for choking, signaling for help by grasping at their throat with their hands. If breathing is obstructed, abdominal thrusts need to be performed. In an unconscious adult or child older than 1 year of age, the most common cause of airway obstruction is the tongue. An artificial airway can be orally or nasally inserted. It will help to keep the tongue in place. If the airway is obstructed for an extended period of time, the hypoxia can cause the heart to stop. If the obstruction is cleared but the patient has no pulse, CPR needs to be initiated. Obstructive sleep apnea, or OSA, is a condition in which during sleep the person is making breathing effort, but there is no or extremely limited airflow. Snoring is common with this condition, and sleeping partners are usually the first ones to notice the problem. Daytime symptoms would include fatigue, morning headaches, and difficulty concentrating. Physical examination of patients with OSA typically reveals obesity, enlarged neck circumference, and hypertension. Those with mild apnea can be treated with conservative measures, including weight loss, avoiding alcohol for 4 to 6 hours before bed, and sleep position modification. The first-line therapy for sleep apnea is a nasal continuous positive airway pressure, or CPAP, applied with nasal prongs. If that is unsuccessful, bilevel positive airway pressure, or BiPAP, can be tried with a face mask or a nasal mask. Untreated sleep apnea can contribute to myocardial infarction or stroke. Nasal fracture will often result from sports injuries, motor vehicle accidents, or physical assault. This is the most common type of facial fracture. If the cartilage or bone is not displaced, complications are unlikely and treatment is not needed. Displacement of the cartilage or bone can interfere with airflow, cause deformity of the nose, and become a potential spot for infection. Diagnosis is by visual inspection for a deformity, a change in nasal breathing, or the presence of crepitation. This is a grating sound or a feeling of rough surfaces rubbing together upon palpation. Imaging studies should be ordered if additional fractures are suspected. Treatment would include pain relief and the use of ice or cold compresses to reduce the swelling. If the fracture is severe, a rhinoplasty may be performed to improve airflow as well as cosmetic appearance. Nasal packing, internal or external splints, or sutures can be used to stabilize the septum postoperatively. The patient should be observed for frequent swallowing postoperatively. This can indicate posterior nasal bleeding. Vital signs are monitored closely, and the amount of drainage on the dressing needs to be observed. The patient should be encouraged to rest in a semi-Fowler position. Forceful coughing and straining at stool, or the Valsalva maneuver, needs to be avoided. Over-the-counter analgesics are typically adequate for pain control, and it may take 6 to 12 months before the end result of the surgery is evident. A clear association has been made between the use of tobacco products and the development of laryngeal cancer. Individuals who also use an excessive amount of alcohol are at the highest risk. Exposure over long periods of time to environmental pollutants such as asbestos, paint fumes, or wood or coal dust has also been shown to be associated with an increased risk. Metastasis can occur to the lung. The larynx, sometimes called the voice box, is directly involved with the production of vocal sounds. A tumor of the larynx will quickly produce persistent hoarseness that does not respond to typical methods of treatment. On page 286, see the green health promotion box, signs of possible throat cancer, including hoarseness that lasts more than 3 weeks, a sore throat lasting more than 2 weeks, consistent pain in or around the ear when swallowing, difficulty swallowing, dry persistent cough for no reason, blood in your phlegm or saliva lasting more than a few days, or lumps or knots in the neck indicating any enlarged cervical lymph nodes. Diagnosis of laryngeal cancer is established by visualizing the larynx with a laryngoscope or a CT scan. A PET scan can also be done of the larynx and throat, as well as MRI, as well as microscopic examination of tissues taken from the site. Once the type of cancer is determined, it will be staged for appropriate treatment. Radiation alone is 85% effective in treating early cancer of the larynx. Radiation can be combined with endoscopic laser chordectomy for certain types of lesions. When possible for organ preservation, the surgeon may perform a partial laryngectomy, in which the thyroid cartilage is split and only the tumor and involved portion of the larynx and vocal cords are removed. A partial laryngectomy does not permanently eliminate the voice sounds. A tracheostomy can be performed in order to facilitate breathing temporarily. However, the stoma will eventually close, and the patient can resume talking after the affected area is completely healed. Chemotherapy can be the initial treatment in some cases of laryngeal cancer. Combinations of chemotherapy and radiation can be used first. The goal is to preserve as much function as possible. A total laryngectomy is performed if the tumor has progressed to surrounding tissues, radiation therapy has failed, or better survival can be obtained by the most aggressive surgery. Near total laryngectomy will preserve voice production and swallowing and is used whenever possible. Extensive surgeries would include the placement of a feeding tube for nutrition until the surgical site is sufficiently healed to allow for swallowing. For patients with tracheal or laryngeal procedures, a swallow evaluation should be performed before food or fluids are resumed. When the patient is discharged from the hospital, a visiting nurse, clinic nurse, or occupational therapist will work with the patient on eating skills if indicated. Endotracheal intubation means that an endotracheal tube is inserted into the trachea through the nose or mouth. This is done with the use of a laryngoscope. In some settings, video laryngoscopes can be used for better accuracy in placement. An endotracheal tube is placed for airway protection against aspiration, when there is upper airway obstruction, and when mechanical ventilation is necessary. Endotracheal tubes are used for short-term respiratory support, such as for immediate relief of airway obstruction, for patients with decreased level of consciousness due to trauma, during anesthesia, or for a few days postoperatively. In a patient with a tracheostomy, there is no connection between the nose and mouth and the lower respiratory system. A tracheostomy can be done to assist in control or ventilation by mechanical means over a prolonged period of time, to facilitate suctioning of secretions in the air passages when a patient with chronic disease cannot cough, to prevent aspiration of oral and gastric secretions, and to bypass a constricted or obstructed airway. Tracheostomy can be an emergency procedure or an elective surgery. If passing an endotracheal tube through the mouth is impossible or extremely difficult, a tracheostomy might be done to provide an airway. When a patient is expected to need an artificial airway for an extended period of time, a tracheostomy is preferred over prolonged endotracheal intubation. Tracheostomy is usually considered after 1 to 3 weeks of intubation. Tracheostomy tubes are available in a variety of materials and styles. Tubes made of metal alloys are used chiefly for patients who need permanent tracheostomy. The age of the patient and the purpose of the tube will determine what features are selected. In a double cannula tracheostomy tube, the outer cannula will act as a sleeve for the inner cannula, which can then be removed for cleaning. The obturator or insertion guide can be used during insertion as a guide. This can be done to protect against scraping the sides of the trachea with the sharp edges of the tube. It's important to note that the inner cannula needs to be cleaned with a pipe cleaner. Fenestrated tubes have a small opening in the outer cannula that allows some air to escape through the larynx. This helps prepare the patient for the time when the tracheostomy tube will be removed and breathing will occur normally again. A one-way tracheostomy valve box can be fitted into the tube opening. This can allow air to be inhaled through the tracheostomy opening, but the valve closes when the patient exhales. This diverts the exhaled air through the larynx and will enable the patient to speak. A cuffed tracheostomy tube has a small balloon encircling its tracheal head. When the balloon is inflated, it fills the space between the outside of the tracheostomy tube and the trachea, thereby providing a seal and preventing the escape of air around the tube. When positive pressure mechanical ventilation is administered, the air passes through the tracheostomy tube only, thus providing sufficient pressure to inflate the lungs. Deflate the cuffed tracheostomy tube prior to suctioning in order to prevent aspiration. The cuff tracheostomy tube may offer some protection against aspiration of mucus and fluids. However, the use of the cuff tube does not replace careful nursing interventions or interventions to prevent aspiration. A patient with a new tracheostomy requires very specialized nursing care, especially if mechanical ventilation through the tube is required. Immediate postoperative care will focus on maintaining a patient airway and observing for hemorrhage. During the first 24 hours, the patient is monitored continuously for signs of respiratory distress. If the patient is unable to cough to remove mucus and drainage, tracheal suctioning is necessary. If the lumen is not kept open, the patient will suffocate. Suctioning is done with strict sterile technique in order to prevent infection. Adequate humidification of the inhaled air can prevent drying of mucous membranes, and hydration of the patient will help to thin secretions. The lungs need to be auscultated before suctioning to assess the need for suctioning, afterward to verify that the procedure was successful and cleared the airway. Head to toe assessment should be performed for any surgical patient. Cuff pressure must be checked with a manometer each shift, also every time the degree of cuff inflation is changed. Preventing infection is another nursing responsibility. Tracheostomy care is a sterile procedure until the stoma is well healed. When changing the ties or Velcro tube holder of the tracheostomy tube, the tube needs to be manually held in place, otherwise it could be dislodged by coughing. Coughing frequently occurs when the tube is moved or manipulated. Psychological support of the tracheostomy patient and family is essential. A Passey-Moore speaking tracheostomy valve can be used by some patients. Explanations about what is being done and why it's being done should be given each time tracheostomy care is provided. Teaching will begin as soon as the patient is alert after the tracheostomy tube has been placed. The patient will need help in facing a future in which they will not be able to speak normally. Initially, depression is common. Address the communication needs for these patients first. The laryngectomy patient needs to be provided with a means of communication, such as a pad or pencil, a dry erase board, picture board device, or electronic devices with appropriate software. Once the tracheal stoma has healed, protection of the tracheal opening from dust and lint can be accomplished through the use of a simple gauze covering or high-necked clothing. To protect the patient from inhalation of extremely cold air, since the patient is no longer breathing through the nose and the mouth, which would normally warm that inspired air, it can be helpful to wear a small scarf over the opening during the winter. A stoma cover can also be used to retain moisture. Proper rehabilitation is important in the acceptance of surgery and its consequences. The speech therapist will help the patient master a new form of speech. Many people can learn esophageal speech. First, they will master the art of swallowing air and then moving it forcibly back up through the esophagus. Then they learn to coordinate lip and tongue movements with the sound produced by the air passing over the vibrating folds of the esophagus. The sounds may be somewhat hoarse, but they're more natural than those produced by the artificial larynx. An electronic artificial larynx is a battery-powered device that is applied externally to the skin of the esophagus to stimulate speech. Another option is an electronic speech aid that has a small tube device that can be inserted into the mouth. Throughout the United States, there are groups that exist for laryngectomy patients who want to get together for social and rehabilitation purposes. One of the primary aspects of community care for nurses is to promote immunization for influenza and pneumonia. Remind the public that frequent hand hygiene and covering the mouth when coughing or sneezing are simple measures that can prevent the spread of upper respiratory infections. Home care nurses will follow up with patients who have had surgery or need further teaching or assessments. Reminding patients to take all prescribed antibiotics as directed is very important in preventing the development of antibiotic-resistant strains of bacteria. Tracheostomy care in the home setting will differ from hospital procedures. In the home, suction catheters can be used longer and can be disinfected for reuse. Extended care facility nurses must be vigilant for signs of upper respiratory infection among residents in order to prevent the spread of infection. Adequate protein stores and hydration will promote immunity for your patients. Timely immunization against influenza and pneumonia is a top priority.